Bonsoir, mesdames et messieurs.
Good evening, ladies and gentlemen. Welcome to Procureur en Parle. Here's Winston McQuaid, spokesperson for Procure, and your MC for our September webinars. This is an awareness month for prostate cancer. Since information is our first line of defense, we're very glad to present the second webinar of this series. Today, we will look at treatment. I think this should be very interesting. So how to pick treatment will be with Dr. Thierry Lebeau. He's been with us already in the past. He's a surgeon and urologist and head of the department at CIS of Eastern Montreal. We'll have a presentation, then a Q&A period. Thank you to the attendees who submitted their questions ahead of time at info@procure.ca. If you have questions during the presentation, then you're welcome to use the Q&A feature on Zoom. Next week, we'll focus on side effects. So we'll focus on answering questions related to the topic at hand today, which is treatment. So we want to thank Industrial Alliance, as well as Astellas, and the Canadian and Quebec Urologist Association. Dr. Lebeau, thank you so much for accepting our invitation. The floor is yours.
Merci Winston, merci de l'invitation à
Thank you, Winston. Thank you for this invitation. Thank you for the opportunity to talk about prostate cancer, which is a huge part of my professional life. I've contributed to Procure webinars before, and the feedback is always very encouraging. I think that with all these new situations, information is crucial in order to handle our diagnosis. So I'm very glad to join you tonight. We're going to talk about initial management of prostate cancer. Of course, it's difficult to talk only about treatment options without some backgrounder. So we're going to talk about some stages of prostate cancer, the Gleason Score, as well as staging. We're going to look at treatment options. Of course, we only have 45 minutes, but I will try to make a little bit clearer all the options. And we try to support patients in their decision making. So we'll talk about active monitoring, radical surgery, radiation therapy, and brachytherapy. We'll discuss why someone would like to pick a given treatment more so than another. And at the end, I'll gladly answer your questions. Of course, we need to carry out screening, the right type of screening. And we did have a webinar on that, so I'll go over that very quickly. But typically, for men aged 50 to 70, we want to establish a screening if life expectancy is at least or less than, that is, 10 years. If PSA is very low, then we can wait for exams because prostate cancer develops typically slowly. Of course, some things are unexpected, but we do have a lot of data that tells us that it is not necessary to perform digital exams, as well as dosing PSA levels more frequently. When PSA is between 1 and 3, we suggest an examination every other year. It is not impossible, of course, for a disease to progress rapidly, but when we look at disease and the epidemiology of the disease, this is the reasonable approach to take. Sometimes we use biopsies and MRIs, And this is how we carry out a diagnosis. The diagnosis is done through a biopsy. A biopsy is a sampling of the prostate tissue itself. In the vast majority of cases, we sample in multiple locations, so typically 12 samples, without looking at one specific spot or lesion. We do have tools that get more and more refined that allow us to carry out a biopsy in a more effective way. A negative biopsy is very reassuring, but it could still be that there's a small bit of cancer, nonetheless, that goes undiagnosed. But if that's the case, then it means the cancer is not significant, most likely, and will not harm the patient or lower life expectancy. I mentioned the Gleason score. We look at two cellular patterns, so you see this on the right-hand side of the slide. A normal prostate will have a 1 Gleason score, and then we can go up to a score of 5. So you can see that the cells become chaotically organized. So these are good cells, good healthy cells, and down here we see that they've lost their normal shape and structure. Pathologists are people who look at biopsies and they try to identify the cellular patterns. So the more aggressive this disorganization is, then the closer to 5 the score will be. And we add the two most frequent patterns. So if there's only 5 plus 5, then there's a score of 10. But if there's a lot of zones at 3 and then some zones at 5, then it could be 3 plus 5, so 8 out of 10. A 6 out of 10, a cancer is not quite aggressive. And if it's less than 6, there's nothing to worry about. Depending on the original PSA levels, we can ask for additional information. There could be an abdominal scan, also a bone scan. We look at bones because metastases typically develop with prostate cancer in the bones. Sometimes we'll use MRIs as well in order to look at the size of the prostate and potentially localized lesions. In this way, we can look at treatment. So these exams are not done routinely, but they give us some additional information as required. These are tumor stages. The first one that we have is T1. So typically, this is detected with PSA levels that are just increasing. But typically, we have patients referred because of blood in urine or semen. Sometimes there can be a nodule on the prostate, in which case it would be a T2 stage. And this progresses to T4. So this means that clinically, we really see and feel the tumor. So at T4, the tumor is easy to feel with palpation, and we have a definite cancer. So now the response will depend, and the risk will depend on the stage, PSA levels, and Gleason score. So the risk is low, intermediate, or high. Not all cancers are the same. We call sometimes cancers things that really shouldn't be called cancers. So it's very important to us when we diagnose people, to have the right words to reassure them. So when we talk about low-risk cancer, it's a cancer that's unlikely to develop, to spread outside of the prostate. These are the patients that we want to identify so that they won't have to go through treatment that will be very inconveniencing. So we want to be effective. In some cases, we want to cure the disease. In some cases, we want to just live with it, because sometimes doing nothing is the best course of action.
Donc, encore un peu la même distinction. Quand on parle d'un cancer à faible risque, on a une très bonne chance de le guérir. En fait, si on opérait tout le monde qui a un cancer...
If we were to perform surgery on everyone, we probably have 90% success rates. I often tell my patients, though, that we have good statistics, but just like, say, a house appliance, some atypical things can happen, and sometimes things will break down. So the possibility for healing is quite high. If the cancer is deemed high risk, then it could, yes, be cured, but there's a little bit of a lower probability. Once the disease reaches the stage where we have metastases, then it will become a chronic disease. Yes, people can die of prostate cancer, but we can definitely extend the quality of life and duration of life. We have sometimes incredulous patients. People say, no, I don't have any medication, I don't have any symptoms, I'm in good shape. Well, unfortunately, there's a strong genetic component to prostate cancer. There are also lifestyle components. For instance, smoking increases the risk of developing a cancer, but sometimes it's just a matter of an unlucky draw. So what are the treatment options? This is the core of my presentation tonight. When we have a localized prostate cancer, so I'm excluding advanced stage cancers here, so we're not going to focus on metastases here. So the treatment options are as follows: active monitoring, surgery, and radiation therapy. Surgery can come in various forms. Radiation therapy could be external or it could be brachytherapy. And active monitoring is considered a treatment, but the idea here is to forego treatment at least for a time. The reason why we don't want to have surgery is that it's, for everyone at least, is that it's not necessarily effective. And there are side effects that patients need to accept. They're not necessarily permanent, but they are definitely there. I talked about the Gleason Score and PSA levels that are lower than 10. Typically, in this case, we try to see what the patient and go to active monitoring. So most likely cancer will be indolent. This doesn't mean that in 10 years we won't change our minds, but it means that it seems reasonable to see how the disease will progress if it does. It's important to know what the anxiety level of patients is, as typically we can lower anxiety, but some patients cannot really live with the idea that they might have cancer, that could develop, and they will want treatment. They will really want this. So when the risk is low, then if we pick a treatment, it means that we want a cure. Even with active monitoring, it means that probably the cancer will be cured. With intermediate risk levels, and if you have specific questions, then you're welcome to please discuss this with your physician. But generally speaking, unless life expectancy is less than 10 years, and then we might have a biopsy. And I won't go into the details tonight, but if the, again, risk is intermediate, the goal will be to cure the cancer. So either with removing the prostate altogether or with radiation therapy. Sometimes clinical studies can also play a role. The higher the risk, the more we'll need to really discuss in depth with the patient. We have to talk about the patient, of course. When there's a diagnosis, the idea is not to fit treatment box. The idea is to say, okay, if we look at the patient's specific profile, then what treatment will serve this patient best? We have a lot of work, so we're not looking for any patients to treat. So we really want to suggest the best treatment options. Typically, we also want to support patients in decision-making, not make the decisions themselves. Some people want their physician to make the decision, but it's always the outcome of a conversation. The takeaway message here is all options are equivalent. They're all valid. So this is true from an epidemiological perspective. I rarely suggest for patients to come to me and say you should have radiation therapy. So if you go to a car dealership and the seller says, no, this is really not the type of car that you want, then you'll listen to this person. So it is my work and my duty to explain why I think a given treatment would not be a good idea. With metastatic disease, again, we won't really talk about that tonight, but prostate cancer is very specific. It's different from, say, a bladder disease. Prostate cancer, depending on the age and type of disease, we typically have several options. That's not the case with many other types of cancer. But we really have a lot of options there that will allow us to prolong a life, sometimes for years, even with advanced disease. We talked about active monitoring. What are the advantages? Well, the idea is to postpone treatment in order to forego side effects and preserve sex life as well as continence, and maintain quality of life and avoid overtreating. The controversy here is overtreatment. So 20 or 30 years ago, we were treating everyone that had a prostate cancer diagnosis. We were saving lives, but we did realize that we were overdoing it. So some treatment
l'objectif est
was
d'identifier les patients qui
useless.
vont bénéficier d'un
So
traitement
the
qui va
idea
pas
is to really
suggérer le traitement
identify
qui passera
which
trop
patients
agressif. On
will
peut
truly
imaginer que c'est
benefit
comme prendre parfois un bat de
from
baseball pour écraser
a
une mouche.
treatment. We don't want
Oui,
to
on va tuer
use
la
a
mouche,
bazooka
peut-être
to
qu'on va
kill
faire beaucoup
a
d'autres
fly,
dommages.
right? Because if we do, we'll kill the fly, but
Les
we'll
inconvénients
destroy
de
a
la
lot of other
surveillance
things as
active,
well.
ben, c'est certainement les suivis réguliers, c'est-à-dire que ça implique une bonne alliance thérapeutique avec
Active
son médecin, ça
monitoring
implique des prises de PSA
involves
relativement fréquentes,
regular
touchés rectaux. Ça
exams,
implique de
so
répéter des
digital rectal
biopsies.
exam as well as
Dans
a
certains
PSA
protocoles, on
level
peut les
dosing.
répéter plus fréquemment, dans d'autres, on les
We may
espace
have
un petit peu plus, mais ça
biopsies
implique d'avoir des
also more
biopsies qui sont parfois des
often.
mauvaises expériences. Il y a des gens qui trouvent ça
Of course,
plutôt
a
anodin, puis il y en a qui
biopsy
trouvent que c'est une
for
très
some
mauvaise
people is
expérience.
no
On
big
peut
deal,
en
and
discuter.
for others is
Puis
a little
essayer de
harder
comprendre les
to
besoins et
go
les
through.
attentes de nos patients.
So this is also something that can
Je
be
vous ai parlé de
discussed.
l'anxiété aussi, puis pour moi, comme
I did
clinicien, ça
mention
reste une des
anxiety.
choses que
As
je
a
perçois le
clinician,
plus chez mes
this is
patients.
something
Puis au fil
that
du
I
temps,
pay
ben,
close
j'ai essayé,
attention
puis
to.
je pense avoir trouvé dans la majorité
Through
des cas des
time, I
mots qui arrivent
think
à
in
apaiser
most
les gens,
cases I
puis qui arrivent
find the right words to
leur
bring
faire
some
comprendre en
peace
fait
to
la
people and to help
non-agressivité
them
de la
understand
maladie. Puis dans une bonne alliance
actually
thérapeutique qui nous permet de faire de la
what the
surveillance qui est
disease
tout à fait
is
appropriée.
about and what active monitoring is.
Il y a quand même de très bonnes études, on ne fait pas du bricolage, le cancer de la
There
prostate
are
étant si fréquent
strong
et si bien
demonstrations
étudié, ben, il y
of
a
the
plusieurs
benefits of
groupes qui ont
active
démontré que c'était
monitoring.
un traitement qui était tout à fait
There were
sexy-séculaire.
many groups
Quand on regarde
where we were
l'exemple
able to demonstrate that active
sur des
monitoring
patients qui
was an
sont enrôlés
appropriate
dans des études
option.
de surveillance active, ben, il y en a 99% qui étaient vivants.
So
Il y en a
90,
beaucoup qui ont été
over
traités. Là, dans cette
90%
étude-là, on parle de 52% des patients, mais la majorité,
were
c'était
still
le choix
living
des patients.
after many years,
Donc, des fois, à cause d'une certaine
after
anxiété,
15
à
years,
cause de
that is.
discussions, à cause d'envie de progresser, puis d'avancer, en fait, puis
So it
de régler
really
le problème.
depends
Donc, dans certaines
with
circonstances, c'est
the
vraiment le
disease
choix du patient. Puis
progression
le
and
choix du
also
patient,
the risk
ça
of
reste très
recurrence.
généralement la meilleure décision.
But
Quand
typically,
on impose quelque chose au patient, on a beaucoup
when
de chances de
we
se tromper.
impose something, we
C'est
typically
important donc,
are
il y
not
a,
going the right
quand
way.
on traite à la progression, ce qu'on appelle
We
la
should go
progression, c'est quand le
typically
PSA augmente de
with
façon
the
significative, quand on
patient's
refait des biopsies,
preference.
puis le score de Gleason n'est plus de 6, mais de 6, mais de 7, 8 ou
If
9 ou
the
10,
Gleason score, say, goes
c'est
from
plus
6
atypique que ça monte
to 7,
rapidement,
8,
c'est des choses qui
etc.,
peuvent se voir.
it typically doesn't
Donc on sait qu'il n'y a pas de différence
increase
de
quickly,
survie
but
quand on traite seulement
we
la
know that there
progression.
is no
Donc
difference
il y
in
a pas,
survival
ça se fait
rate with or
au
without
détriment
treatment
de la
in
survie, le
such
fait qu'on retarde le
cases.
traitement.
So survival is not
Donc, les messages à
affected.
retenir pour le traitement,
So
pour la
the
surveillance
key
active, c'est
takeaway
que les
here
effets sur la fonction sexuelle
is that the effects on
et urinaire sont
urinary,
diminués.
erectile,
Ça a
and
moins d'impact sur la
sexual
qualité de vie si on ne fait
functions
pas de traitement.
are not
Après,
disrupted,
je vous ai parlé beaucoup
which
d'anxiété, mais c'est vrai que
maintains
l'anxiété
the
peut
quality
devenir
of life.
parfois
I did
envahissante et
mention
avoir un impact
anxiety,
significatif sur la
so
qualité de
anxiety
vie. Donc, il faut
levels, of
mesurer
course, also
le pour et le contre de tout
can
ça.
impact life. So it's a
Quand on parle
matter
de
of looking
chirurgie
at
radicale, ben,
risk
l'objectif, c'est
and
d'enlever la
benefits.
prostate, les vésicules séminales.
Now, with
Dans
prostatectomy,
certaines circonstances, les
the
ganglions qui
idea is
sont
to
autour de notre
remove
prostate,
the
on
prostate, and
les
in
enlève
some cases, some
systématiquement,
lymph
pardon,
nodes
d'autres les
also
enlèvent
around
jamais.
it.
Puis la majorité des gens les enlèvent dans certaines circonstances pathologiques, selon le PSA,
Sometimes they
selon le genre
need
de
to
maladie
be
qu'on voit à la
removed.
biopsie.
It really depends
Donc ces trois
on
approches
the
qui, dépendamment de qui
biopsy.
les fait, vont donner d'excellents résultats. On ne peut pas vraiment prétendre que la chirurgie ouverte est supérieure à la chirurgie laparoscopique ou à la
All three
chirurgie
options, so
robotique.
open surgery,
Il y a des bonnes
laparoscopy, and
études qui
robotic
démontrent
surgery,
que
they're all
moins la
effective.
chirurgie est invasive, plus la récupération
But
est rapide.
typically, recovery is easier with a less invasive procedure. So that's typically what we favor, but in all cases,
On peut faire une excellente chirurgie ouverte.
surgery is extremely effective. The key here is not really the means of surgery, but rather to carry out the surgery.
Donc, on a une très bonne idée de l'envahissement local de maladie.
We can also have a good idea of the spread of the cancer because we have the whole prostate on hand for examination. The concrete success of the surgery is warranted by the PSA levels that should be at 0. So if PSA levels is not at 0, it means that some cells are still circulating in the body. In this case, we might look at radiation therapy. prostate cancer is very different from breast cancer, but typically we do surgery, radiation therapy, and chemotherapy for breast cancer, for instance. So with prostate cancer, we have some leeway, and we can adapt depending on the situation. What can happen with surgery? Well, of course, sphincters are very close to the prostate, so we can have urinary dysfunction. I carry out this type of surgery every week, and I do have good results, but some patients will be incontinent. So it really depends on the body, how the body recovers. So it's important to explain this to people. Erectile dysfunction is pretty frequent. About 50% of men do develop it after prostatectomy. But a lot of these patients do not have a normal erection beforehand. Anyway, so this does not improve erections. The surgery requires typically 1 day. It does require a hospital stay. Typically, patients post-surgery will spend 1 night in the hospital, and then they'll keep some equipment, so a catheter for a week. Again, the more the team is experienced, the better the patient can recover. Yes, complications are rare, but they can happen.
La radiothérapie externe.
Now, radiation therapy, or external radiation therapy in this case, this is a treatment that destroys the cancer cells, and I will have some colleagues who will talk about that in the next couple of weeks. So they will be able to answer your questions much better than I. So I have a lot of patients that I see that do undergo this type of therapy. Sometimes we need to have prostate markers in order to really identify where to aim the radiation therapy. This is typically 20 to 28 sessions. They're about 20 minutes long. This is part of the benefits of radiation therapy. It's not as radical as surgery. It's more indolent. So yes, it's constraining because for about a month you need to go to the hospital for a short period of time, but it still allows people to go about their daily life. It does cause a fatigue that is significant, and side effects can develop whether with erectile function or urinary function. So with both surgery and radiation therapy, the quality of life outcomes are similar. The benefits here, according to studies, after 1 year, again, quality of life is just as good as surgery. Again, the treatment is short. If you live, of course, far from a center that can do this, then it would be a problem. So this could be a reason for a more radical procedure, such as surgery. There is no hospital stay, and again, no effort-based incontinence. Sometimes we have a pressing need to urinate, and that can have an impact on quality of life. Disadvantages were already mentioned.
un des inconvénients qu'on a quand on fait de la
One of them,
radiothérapie, c'est qu'on
when
n'a
we
pas de
do radiation
spécimen de prostate qu'on enlève comme dans une
therapy, is that
chirurgie. Donc, on n'a
we do
jamais
not have
le
access to the
diagnostic
prostate
complet
itself,
et
so
total
we
de la
don't have a
prostate. C'est
full
beaucoup plus l'évolution qui va
diagnosis,
nous
a
le dire.
full view
On
of the
associe
prostate,
souvent
as
la
compared to
radiothérapie
surgery if we remove the
abdominothérapie, qui fait
prostate.
que très rapidement, le PSA va diminuer de façon très
Quickly,
significative.
PSA
C'est pas une
levels
diminution qui est factice,
do
mais
decrease,
c'est pas comme si on avait enlevé la prostate, on avait enlevé
but
toute
it's
la
not the
source de
same
PSA.
as
Donc, c'est vraiment
removing
le recul
the
qui va nous
prostate.
permettre de savoir si
So
on a
it's really
bien
with some perspective
contrôlé, voire
that we'll
éradiqué la
be
maladie.
able
C'est pas
to
un mauvais
know
traitement du tout, la
what
radiothérapie. Puis comme je vous
the
ai mentionné tout à l'heure, dans
what
plein de
the real
circonstances,
outcome
c'est tout à
is.
fait équivalent à la prostatectomie. On parle un peu de
Like I
philosophie
said,
ici, à savoir
prostatectomy is
si c'est
equivalent to
important ou
radiation
pas d'avoir
therapy
complètement
as far
enlevé la
as
prostate
outcomes goes
plutôt que de
in
se
many
baser uniquement sur
cases.
le toucher rectal ou la résonance magnétique. Mais il reste que c'est un avantage de la
Still,
chirurgie.
though,
La curithérapie, je pense
it
que j'ai
really
passé mes
depends.
échos, oui, là, voilà. La curithérapie, c'est une option dans certaines circonstances. On va
Brachytherapy is
mettre
an
des
option
implants
for
radioactifs dans la
some
prostate.
patients.
Ça nous
So
permet
we
en fait
input
de mettre des implants qui vont dégager de la
an
radioactivité pendant
implant
plusieurs mois
inside the
et
prostate,
qui vont
so
atteindre
there
les
will
cellules de
be
prostate.
a
Il y a certaines
radiation
précautions à
therapy
prendre
from
quand on
this
est en
implant
contact de femmes
for a
enceintes
few
à
months.
cause justement de la radioactivité, mais ça, c'est pas des choses qui
Because
sont
of
prises à la légère, qui
radioactivity,
sont toujours très bien expliquées par les équipes de radiothérapie.
there are some
Quand on
measures
parle
in
de
place for
curithérapie à
contact
haut
with
débit,
pregnant women,
c'est
for
qu'on fait de la
instance.
curithérapie et en plus de ça, on ajoute la radiothérapie externe.
On top of
Pourquoi on
this,
fait ça?
we
C'est pour
typically
moins de
add
traitements
external
généralement de
radiation therapy, so
radiothérapie
that
avec moins de
radiation
radiation. Puis
therapy
l'espoir de tout ça, c'est d'avoir
will
un
be
bon
done
traitement
over a
oncologique, c'est-à-dire
reduced
de
number
guérir
of
le cancer
sessions.
et de
And
minimiser
typically,
les
the
effets
idea here is
secondaires
to cure the cancer and to
qui sont
minimize
dus au traitement
side
soit de la
effects.
curithérapie ou de la
So, side
radiothérapie.
effects due to either
Les
treatment.
avantages de la curithérapie, c'est que c'est relativement rapide. Ça se fait tout de même
Benefits,
sous
it's
anesthésie.
pretty
Ça se fait généralement dans un
quick.
setup qui ressemble un petit peu à une salle d'opération. Il y a potentiellement moins de dommages aux tissus
There
voisins, que
isn't
ce soit
really
les nerfs
damage
érectiles
to
ou le rectum.
neighboring
Ça
tissues,
permet de poursuivre les activités quotidiennes plus rapidement que si on avait eu
and
une
we
chirurgie.
can just continue with
Donc,
our
la
normal
récupération est plus
activities.
rapide. Quand on
Recovery
parle
also
d'une
is
curithérapie à
quicker
bas débit, quand on fait une curithérapie à haut débit,
with
ça demande quand même certaines séances en
brachytherapy.
externe, donc c'est déjà un peu plus contraignant.
There are a little more
Pour pouvoir faire de la
restrictions.
curithérapie, justement, ça nous
For
prend une taille de
brachytherapy,
prostate
again,
qui est raisonnable.
we
Entre guillemets,
need
il
a
faut pas qu'elle soit trop
reasonable
petite parce
size
que
of
c'est
the
surtout, on n'est pas
prostate. It
capable
cannot
de
be
mettre
too
d'implant. Il ne faut pas qu'elle
small,
soit trop grosse parce que si elle est
and
trop
it
grosse, on
can't
n'est
be
pas
too
capable de
big
mettre suffisamment
either.
d'implant pour avoir un impact. Il ne faut pas avoir de difficultés urinaires parce qu'elle va faire
There shouldn't be
fluctuer la fonction
any
urinaire de façon importante. Il y a des gens qui sont déjà dans un
difficulty
certain
with
état d'instabilité.
urinating.
Faire de la curithérapie, ça peut faire qu'il y a encore plus de difficultés à faire
Because
pipi.
this
Et
procedure can impact the ability to urinate, and of course, you have to be eligible to be under anesthetics.
C'est parce qu'on pense que l'espérance de vie des gens.
Again, if we do decide to either do surgery or brachytherapy, it's always because we do believe that the patient can live over 10 years. If someone received brachytherapy and has cancer recurrence, then things are a little more complicated with some specific centers. Sometimes we move to surgery in some cases, but these are specific circumstances. Again, brachytherapy can lead to urinary difficulties. Okay, the next slide is starting to show. All right, you see the advantages, disadvantages. So this is a bit of a summary of what I already just mentioned. The key takeaway here, all these options are valid. They're just not applicable to everyone. It depends on the patient, their general health status, their general condition, and in some cases I say, well, you're a very good candidate for a good treatment. Under other circumstances, we suggest some treatments that I think would be better fitting. How do we pick now the treatment? Well, again, it really depends on several factors: your age, health condition, life expectancy, type of cancer, your values, your erectile function, and your urinary function as well. We do discuss patients if they haven't had sex life in many years, then this is not really an issue. So they don't mind postponing treatment. Urinary function is a different thing, but since the incontinence is typically not too significant, again, depends. It's simply a matter of having a discussion. If we have low risk cancer, then we do recommend active monitoring. Sometimes we move to treatment because the patient insists, and again, oncological outcomes are very positive. But of course, we need to weigh the side effects. With an intermediate risk, then it's really a matter of balance. It depends on the wishes and expectations of the patient. I think all urologists and radiotherapists that I know agree. Typically, we ask the patient to meet with a radiotherapist so that they can see their perspective, what they could expect if they choose that route, and what the treatment entails, and what's the planning related to these treatment options. We do have the chance with prostate cancer to not be in a hurry. We can think things through, and we can take our time for decision making. This is quite a luxury, of course. Sometimes we're in a hurry, but in this case, we do have time for decision making. If the disease is high risk, then sometimes we can look at surgery, especially for younger, healthy patients. We'll try to really stop the cancer in its tracks. We could also add other treatments on top of that. For some cases, surgery will be better, especially for younger, healthier patients. But of course, surgery also requires some recovery time. And there could be specific factors where we could think that surgery is not really the best fit. The older we get, then the more we suggest radiation therapy, simply because the benefits of radical surgery is not as present. Typically also for older patients, recovery is more difficult post-surgery. If we have important urinary symptoms, which is rare, but some men are 65 or 70 and they have difficulty urinating, and it could have nothing to do with cancer. It could just be enlargement of the prostate. So some treatment can increase these problems, make them worse. So they may require, say, a catheter or other things. So if that is the case, then we tend to move to surgery. Again, if you're over 80, then surgery is not an option, even with urinary symptoms. Hormonal therapy and radiation therapy will be much better in this case. So after treatment, what do we do? I'm hearing someone. Is somebody speaking? No? Okay. So when PSA levels rise post-treatment, we need to know how to interpret this. This is a question that comes back often. So what we know about the biology of prostate cancer is there are still cancer cells that are circulating through the body even after surgery. So if we remove the prostate, PSA levels should fall to 0. But if there are leftover cells, they could be cancer cells that are not very active, but they're somewhere in the body, then PSA levels could remain over 0. And there are other conditions also that could lead to a higher PSA level, so that have nothing to do with cancer. So that's why we have to check. We're very lucky to have PSA levels that we can look at. This really helps us, and it provides information that we can never have from scans or other types of examinations. Follow-up is done over several years. When I diagnose a cancer, I typically suggest, in some cases, to follow up after a few years. If there's no evidence, though, that the disease is there or progressing, then we can simply follow up. But if after 10 years PSA levels and everything else is stable, then we can stop monitoring. With each follow-up, we ask for a PSA dosing. If the levels are low, then we look into things, but if levels are rising, then there could be cancer or recurrence, and we need to manage it appropriately. This is an illustration of PSA levels. So we see PSA levels rising, there's a diagnosis, then there's radical prostatectomy. So say PSA levels were at 10. We remove it, PSA levels are at 0. Then we can have a biochemical recurrence. So we don't really know, there's no symptoms. So if it's over 0.2, this is called a biochemical recurrence again. There's no metastases in this case, so sometimes we'll do radiation therapy. This is done where there were issues as a remedial treatment. It could be that PSA levels increase again. That means that some cells are still producing PSA. This is directly correlated to the presence of metastases. When we carry out radiation therapy, the situation is different. We cut down on testosterone, and then PSA does not reach 0, but it is reduced. It is typically under 1, maybe around 0.3 or 0.5. So why do we still have PSA? Well, because some prostate tissues and prostate cells have the potential to secrete PSA still. In conclusion, we're going to get to your questions in a bit, but the takeaways here is that we shouldn't treat all patients. We select the right patients that will benefit from treatment. So of course the benefits have to outweigh the disadvantages. We can cure prostate cancer if it's localized and detected early. Treatment can have repercussions on urinary, erectile, and intestinal functions. There are strategies to prevent complications again. This all needs to be thoroughly discussed. We do need to have resilience, so there can be sex life for both men and women, men and their partners, whoever they are. it requires some resilience and adaptation, but it can be done. Some people need to have extra support with their expectations with regards to their sex life, and they can just adapt to these situations. We could use artificial sphincters in some cases. Some patients are really wanting their erections back, so it really depends in this case. Future hope. Well, treatment is good. Treatment options are good, and they keep improving. Very much improved with regards to what we had, say, 10, 15 years ago. We're all very much invested in what we do in improving management of the disease, also managing side effects, complications, etc. So I think we need to maintain that, and organizations like Procure really help us in developing resources. There you go. Now I'm going to give the microphone back to Winston. Thank you so much. I'd like to say first that the presentation was extremely reassuring. Information is very clear, comprehensive. Thank you so much. And yes, and now we reach the stage for questions. What is the acceptable delay where my stage 2 cancer will not progress with a Gleason score of 4+3? My biopsy was in April 2022. This is a question that we do ask ourselves because of the timelines with surgery in the context of COVID. We have medical literature that says that 6 months are typically not harmful. Again, there is no one answer. If we decide to delay treatment, then there is some risk for progression, but typically 6 months is okay. And we did have databases of patients that had to have their surgery delayed, so we knew that the harm is rare. Also, as a side note about a patient like this one, some patients have a disease like this and they want active monitoring. So even if it's a little bit outside of standards, that is a possibility. Again, this is a shared decision made with the patient. We don't have a crystal ball, but over 6 months, it would be very atypical for the disease to progress significantly. And if so, then we can wonder if treatment done 4 months earlier would actually have changed outcomes. Right. There are situations where we can't really know. Okay, another question. I'm 70. Cancer is grade 2, 3+4. PSA levels at 5.7. The urologist tells that the cancer is localized on one side of the prostate. I'm in good shape, no symptoms. I prefer to not undergo treatment. Would I regret it? And how much time do I have before metastases? Well, this is precisely the situation that I described just a moment ago. Could you regret it? Well, unfortunately, yes. But typically, you would see your urologist again. Sometimes we dose a PSA more regularly. So in just 3 or 4 months, it's very rare for disease to progress significantly. So the idea here is to look at what we want to do. But yes, active monitoring is absolutely valid in such a situation, knowing that if one day we decide to act, then the disease will have progressed somewhat. And of course, as we age, some options, say surgery, will no longer be appropriate options. So as we age, the treatment option will be radiation therapy, which isn't bad, but it simply depends on your preference. Okay, third question. We have 3 generations of prostate cancer, grandfather, father, and 2 of my brothers. I was just diagnosed with a Gleason score of 6 at 62. My urologist suggests active monitoring. I'm hesitant. Should I treat my cancer? Hesitant due to family history, that is. Yes, this is a good question, and unfortunately a frequent one. The question of screening and family history. Well, we can't really conclude that an aggressive cancer is correlated with a family history. We do understand that this person is concerned here. So I think the first step is to focus on these concerns. If we can't reassure the patient, then we can move to treatment. But typically, the best decision is yours, like I tell my patients. Yes, it involves a lot of anguish and stress, definitely. Next question. My partner is 60 and under active monitoring since 2019. He just had his 3rd biopsy. My questions are, can the biopsies spread cancer cells to neighboring tissues? And how many biopsies will be carried out before we need to stop we can't stop the procedure? So biopsies are not concerning in 99% of cases unless the disease is very much atypical. So no, biopsies do not tend to spread cancer cells. This is not a legitimate concern to have. How many biopsies? Well, it really depends on the protocol. It depends on the age also. So I think 2-3 biopsies is very much standard. Typically, if we reach a higher number of biopsies, then there are other questions that should be asked. But I can't tell you how many years this should go on. I've done 2-3 biopsies for some patients. Everything was stable, so then they haven't sought medical attention in a few years. We could miss out on a little cancer cell foyer, but if we do a 3rd biopsy and the cancer hasn't progressed, even if we would have missed a spot the first time around, we can still, we've checked 36 spots, so we can be quite confident. So it's extremely rare that we go over 4 biopsies. Yes, in my case, 2. The first time, nothing, and the second time, there was cancer, and then we had to make a decision. Okay. I am 50. I am under active monitoring. My PSA levels are stable. My concern is to be 69 and having to pick treatment when I will not be in as good shape. So should I treat my cancer now? This is a good question. And my philosophical answer is we should be anchored in the present. We don't know what is coming, right? So I think we need to make decisions according to today. You all have examples, right, of people who shouldn't have been involved in an accident or develop a disease, etc. So speaking here of life when it will be, as it will be in 10 or 20 years, I think this isn't necessarily the right path. Then if anxiety related to that is crippling, then of course we can treat. Another question, surgery in 2015. So 5 years later, my PSA levels were at 1.3 and now 2.15. So on one side, I was recommended with hormonal and radiation therapy, and on the other side, to wait. My bone scans are negative, and we don't see anything under imaging, so I'm a little bit bothered by the idea of radiation and hormonal therapy. Should I wait? Well, in order to really answer that question, I would need more details. Typically, if this patient is healthy, the risk of postponing treatment is low. And if we move to remedial therapy, then the goal is not curative. I'm missing too much information in this case to really answer well. Okay, last question. I'm giving a choice between surgery and radiation therapy with hormonal therapy for a cancer located in 50% of two lobes. My Gleason score is 4+3. I'm 68. I'm hesitant because I'm thinking that I will likely have radiation and hormonal therapy afterwards anyway. Am I right? Well, again, on paper, this patient is a good candidate for either treatment. So it's hard to tell which course of action would be the best. Sometimes I present surgery with, yes, almost a certainty that we will have radiation therapy afterwards. With the amount of information that we have, this gentleman may have radiation therapy. About 20% of people have remedial radiation therapy, but there are no factors that tell me that this would be the case, likely the case for this gentleman. So again, it really depends. I did have a radical prostatectomy, and 2 years later I had a recurrence with 28 days of radiation therapy, and since 2005 I see my urologist once a year, and my Gleason score is always the same at 0.1 or 2 with my PSA levels. So there is hope. Even if you're scared of a recurrence, this can be treated also. All right, so Dr. Lebeau, I'm always tempted to call you Thierry. Well, you may. So now we're wrapping up with questions. I really want to thank you again for an excellent, very clear, comprehensive presentation. You're very poised and reassuring, and it's highly appreciated. I'm sure that the public also appreciates. So Dr. Lebeau, our next webinar will be September 20th. We're going to look at urinary, sexual, and intestinal problems with Peter Babassis. He's a radio-oncologist. So please be there and have a look at procure.ca in order to be in the loop. Thank you so much. This is Winston McQuaid with Procure en Parle. See you next week.
Vous avez aimé les services de Procure? Alors n'hésitez pas à contribuer à procure.ca. Merci pour votre générosité.